On to the next presentation. Our third speaker of the day is Professor Feng FENG, Director of the Department of Radiology at Peking Union Medical College Hospital, discussing clinical application of AI-enabled one-stop neurocardiac MR imaging.
The organizer for inviting me to present our work at this conference. Before that, I would like to comment on Professor Wu's talk. It really reminds me of my first MR scanner in 1994. That was a 0.3 permanent magnet from Hitachi. We did great clinical work on that system, but it didn't do DWI. So in my concept, low field strength magnet should do DWI. So your work is really good. Yeah. So I would like to talk about AI-enabled one-stop neurocardiac MR imaging and its clinical applications. Disclosure. First of all, I would like to provide some background so that we can appreciate the work. Cardiovascular diseases and cerebral vascular diseases are strongly coupled. Together, they are highly prevalent and remain a leading cause of death in China. There are approximately 330 million these patients. And in a recent report, there were 6.69 million patients died of this disease in the year of 2021. Among these patients, 49% of them have had both carotid and coronary artery stenosis together. In addition, 68% of stroke patients had also concurrent coronary artery diseases. Cerebral vascular diseases in China showed significant geographic disparities. As shown in this map, red color indicates high-risk regions, whereas orange color shows relatively low-risk areas. In general, northern part of China have higher stroke incidence, likely because of lower hypertension control and a high sodium diet. In contrast, southern China coastal area had more cardioembolic stroke. In the southwest mountain regions has exhibited more small artery occlusion stroke. Neurocardiac comorbidity has attracted enormous attention. As described here, dyslipidemia, hypertension, and diabetes mellitus drive polyvascular atherosclerosis, which leads to cardiocerebral vascular diseases. Cardiovascular diseases can cause cerebral hypoperfusion, which leads to brain ischemia, stroke, and many brain function impairment. Conversely, ischemic stroke can induce cardiac injuries through many mechanisms, as shown in these figures. neurocardiac co-management has become a global priority recently. For example, at the ICMRM annual meeting in 2025, there are multiple scientific sessions and educational courses focusing on this topic. Recent publications suggested strong heart-brain connections. These studies have shown 80 associated genomic loci were identified for heart MRI traits with shared genetic influences with cardiovascular diseases and brain diseases. And there are correlations between cardiac structure and function and the neurologic clinical outcomes. Multiple studies suggested MRI play an important role in neurocardiac co-management. One combined brain-heart magnetic MR study can offer one-stop evaluation of heart failure-related cognitive impairment. One-stop neurocardiac MRI can also assess cerebral and cardiac microvascular diseases. The concept of the heart-brain axis was recently proposed. This system can modulate cardiovascular risks and affect cognitive functions. To use MRI as the in the neurocardiac co-management, we have to address several technical challenges. One of them is standardization. This is critical to broader clinical adoption. Recently introduced deep learning-based reconstruction can significantly shorten the scan time, but it also introduced considerable challenge for standardization. Do we need to use deep learning-based reconstruction? If we do, what kind of deep learning-based reconstruction to use? And how are we going to mitigate vendor-to-vendor differences? As usual, the technique standard for scanning procedure needs to be established. This include quality control and the consents of the scan protocols. To promote the one-stop neurocardiac MRI standardization and to support multi-center trials, we have formed a work group with 69 participating hospitals in different regions of China and 52 experts together to develop the consensus statement. This work was supported by the Ministry of Industry and Information Technology. After 2 years, we started this work in the March of this year. After 2 years of preparation, we have our first official meeting in July of 2025. And we drafted the initial consensus statement. And after 2 months of discussion, we have another meeting in October and finalized the manuscript. The one-stop neurocardiac MR protocol consensus was released at the Chinese Society of Radiology annual meeting 3 weeks ago, and the consensus statement was released to public at the conference, at the CSR conference 3 weeks ago, and also the consensus statement was published in the latest issue of the Journal of Chinese Medical Imaging Technology. Now let me highlight the one-stop MR, neurocardiac one-stop MR protocol in the consensus. We start with pre-contrast brain MRI with T2, fast-beam echo T2, and the T2 flare, T1 flare, and DWI in less than 5 minutes. Then we move to the head neck vessel wall imaging using 3D high-resolution T1 plus 3D TOF MRA. Then we perform cardiac MRI using SSFP-CINI to guide the short axle 4-chamber, 2-chamber left ventricle outflow tract images. Then we give a contrast injection. During the first pass, we acquired cardiac perfusion. Then we spent 5 minutes to do the contrast enhanced head and neck vessel wall imaging, use the same sequence previously used. Finally, we do the myocardial late gadolinium enhancement sequence. Our goal was to complete the one-stop imaging protocol in less than 30 minutes. How can we do that? That deep learning approach can be a great help. Here is one example. In conventional MRI, in conventional brain MRI examination, we acquired the T2. It takes almost 1 minute to acquire T2. But using deep learning based imaging, then the scan time was half, and the image quality remains to be excellent. Similarity for T1 flare, T2 flare, and DWI, the deep learning approach can considerably reduce the scan time without compromising the imaging quality. Now let's discuss what kind of patient population will benefit from this one-stop neurocardiac imaging. We first applied this protocol to suspected cardioembolic stroke that can jointly assess the brain and heart structure and the function together and identify the embolism cells. And then we applied the suspected brain heart syndrome patient population would be benefit from this protocol to see simultaneously assess cerebral and myocardial function to prevent and manage the complications. Polyvascular atherosclerosis patient also can benefit from this protocol, so we can comprehensively to evaluate the lesion burden and monitor the progression of the disease, that as well as in the TIA and the mini stroke patients. Potentially, we can find the risk factor to optimize secondary prevention. And finally, for the high-risk population for cardiovascular, cardiocerebral vascular disease patients, we also can do that to see if there is some combined lesions to help us to make a comprehensive, better treatment decision. At this point, I'd like to show some clinical cases. First, I would like to show CT cases. This was a 65 years old man with a history of hypertension and atrial fibrillation, who presented with sudden generalized seizure and 4 hours of coma. This one-stop neurocardiac CTA examination revealed a left atrial appendage and the occlusion of the right internal carotid artery and the ME segment of right MCA. Plus the CT perfusion, we can see the abnormal perfusion of the right cerebral hemisphere. And this case provides motivation for one-stop neurocardiac MRI evaluation. Can we do the similar examination using MRI? And here comes our first case of the MRI one-stop neurocardiac imaging. The case was a 37 years old man who presented headache with left-sided visual field deficit, chronic visual field deficit, motor aphasia, and recurrent stroke. He also had a past medical history of intermittent chest pain for 4 years and a long-term history of smoking and alcohol. He also did atrial septal defect closure procedure in his childhood. In this brain MRI, we can see multiple infarct foci, one in the left frontal lobe Broca area, according to his aphasia, and the other one was in the right parietal lobe with the visual field deficit, and also from the top MRA, the digital branches of both demonstrate a poor visualization of the digital branches of both MCA and the PCA. On cardiac imaging, the LGE demonstrate hyperintensities in the basal inferior and mid-anterior segments of the left ventricle, indicating chronic myocardial infarcts. This case highlight the neurocardiac comorbidity, and probably we should do more comprehensive evaluation of this kind of patient to help the clinical treatment decision-making. The second case was a 62-year-old man with cerebral infarction, coronary atherosclerotic heart disease, hyperlipidemia, and grade 2 hypertension. Brain MRI showed chronic and old infarction in the right occipital lobe with the encephalomalacia and gliosis, along with multifoci of ischemic lesion on T2 flare. In the vessel wall imaging, we can find the wall thickening and the plaque formation in the right MCA and right PCA here. Additionally, on cardiac imaging, LGE also showed multiple hyperintensity, myocardial hyperintensity, suggesting chronic myocardial infarct secondary to microvascular occlusion. The third case was a 72-year-old man with bilateral lower limb weakness, recurrent cerebral infarction over more than 2 months. He had a long history of hypertension for over 30 years and hyperlipidemia for over 20 years. Brain MRI on T2 flare and DWI, lacune chronic infarct was shown in the right splenium of the corpus callosum, and the recent onset infarct in the left corona radiata. On the MRA, stenosis of internal artery is noted. But with the high resolution vessel wall imaging of the head and neck, we can see continuous atherosclerotic plaque formation in the C1 segments of both bilateral internal carotid arteries with mild stenosis, as well as atherosclerotic plaque in the basal artery. On cardiac MRI, LGE images demonstrate hyperintensity in the basal inferior septal segment of the left ventricle. This was not noted in his history of the record in our hospital. So these cases highlight the comorbidity of the cerebral artery diseases and cardiovascular diseases. They are strongly coupled, and they underscore the need for one-stop neurocardiac MR imaging to comprehensive assess the patient's conditions and enable better informed treatment decision and prevention strategies. So in summary, we have seen cardiocerebral vascular diseases coupling has attracted enormous interest, and it has become a global priority. In China, an expert consensus for one-stop neurocardiac MR protocol has been developed, benefiting several patient populations. From a technology's perspective, deep learning is critical enabler for one-stop MR protocol. And we have shown several clinical cases. This demonstrated the value of the one-stop protocol and the importance of performing neuro and cardiac examinations simultaneously. Presently, the protocol isn't included coronary artery imaging due to the scanning time limitation. And in the future, the protocol can be expanded, include that as the technology continues to advance. With that, I thank you for your attention.
Professor Feng, ladies and gentlemen, please stay with us. Now, Professor Yu would like to present to you a souvenir as a token of appreciation.